Peptic ulcer is defined as a loss of continuity of the gastric or duodenal mucosa larger than 5 mm as seen in endoscopy. If it is smaller than 5 mm, then the lesion is called erosion and not ulcer. This diagnosis depends on the endoscopist's estimation and it is slightly subjective. The alternative and more objective definition of ulcer is pathological, where ulcer is the loss of gastric lining that extends deep to the submucosa. On the contrary, erosions are more superficial lesions. The endoscopic or pathological finding of fibrosis or scarring at the bottom of the ulcer indicates chronicity of the condition. Peptic ulcers include both gastric ulcers and duodenal ulcers. These show significant differences both in terms of pathogenesis and clinical data. Duodenal ulcers are in the duodenum, coexist with antral gastritis, have been associated with high acid production, and have never been epidemiologically associated with duodenal adenocarcinoma. On the other hand, gastric ulcers are in the stomach, are combined with body gastritis and gastric atrophy. Gastric acidity is not increased, and have been epidemiologically associated with gastric adenocarcinoma. Gastric ulcers are further divided into subtypes depending on their location. Again, different location indicates different biological behavior. Type 1 are the ulcers located in lesser curvature and the proximal antrum. Type 2 are those met together with duodenal ulcers and can be their consequence. Type 3 are the ulcers located at a distance less than 2 cm from pylorus and are commonly called prepyloric. Type 4 are ulcers located in the proximal stomach and cardia. They are usually due to underlying conditions. For example, Cameron's ulcers are in the cardia and are due to a hiatal hernia whose ring exerts chronic pressure on the prolapsed stomach. Type 5 ulcers are those that are due to nonsteroid anti-inflammatory drugs. There are many causes of peptic ulcer, but almost 90% of cases are due to Helicobacter pylori and non-steroid anti-inflammatory drugs. Helicobacter is a gram-negative rod that produces urease, an enzyme that breaks down urea to produce ammonia. Ammonia neutralizes acid and allows the microbe to survive. The microbe is transmitted by the fecal-oral, or oral-oral route, and colonization of the stomach leads to gastritis. The incidence of infection is influenced by the age of the individual. Increasing age increases the likelihood of exposure to the microbe. Only 5 to 10% of the infected will develop an ulcer, but early epidemiological studies proved the involvement of the microbe in ulceration process, and that its eradication leads to cure. Any area of the stomach can be infected, but the location of infection and subsequent gastritis is affected by the acidity in the stomach. If it is high, then gastritis develops in the antrum and is accompanied by duodenal ulcer. When the gastric acidity is low, gastritis develops in the gastric body and is accompanied by gastric ulcer. Helicobacter leads to duodenal ulcer because it increases acid production and suppresses bicarbonate production. Infection by Helicobacter and inflammation of the gastric antrum increases acid secretion through many pathways. The local neutralization of acid by ammonia prevents the stimulation of D cells resulting in the non-production of somatostatin. Similarly, it maintains stimulation of G cells resulting in hypergastrinemia and eventually hyperacidity. At the same time, it suppresses the normal inhibitory neural reflexes of antrum on fundic parietal cells. Helicobacter infection also decreases bicarbonate secretion through duodenal dilatation, and by decreasing the activity of nitric oxide synthase. The acidic gastric content leads to gastric metaplasia of the duodenal bulb, which is subsequently colonized by Helicobacter and inflamed, contributing to the ulceration of the adjacent normal duodenal mucosa. For reasons unknown so far, some strains of Helicobacter are more ulcerative than others. This may be attributed to the secretion or production of cytotoxins such as VAC-A, CAG-A, BAV-A, when the corresponding alleles are present in the genome of the microbe, to overproduction of urease, which in turn increases production of ammonia and ammonium chloride, known to be cytotoxic. and to an excessive synthesis of bacterial phospholipases A and C. These disrupt the hydrophobicity of the mucosa by breaking down its phospholipids. When the acidity of the stomach is reduced, infection with Helicobacter causes body gastritis. This reduces further acid secretion, exacerbating atrophy, leading to intestinal metaplasia. It should be emphasized, however, that, despite the decrease, the amounts of acid secreted by the mucosa remain significant. The gastritis inflammatory response induces interleukin-8 and interleukin-1 beta synthesis, which attract macrophages and neutrophils to the mucosa. These in turn, release free oxygen radicals, leukotrienes, and lysosomal enzymes. All these destroy the defensive mechanisms and exert a corrosive and ulcerative effect. The subsequent activation of lymphocytes, and further secretion of cytokines and TNF-alpha provoke the activation of complement and platelet activating factor. This enhances the ulcerative state. The outcome is the diminished resistance of cells, even to low amounts of acid, ending in mucosal ulceration. Gastric ulcers are usually located at the antrum body boundary at the transitional zone from the body type to the antrum type mucosa. The association of nonsteroid anti-inflammatory drugs with peptic ulcer is well known. Endoscopy after a 3 months treatment with a daily low dose of aspirin will reveal that 15 to 30% of the patients will have one or more ulcers, mostly gastric ones. Even though, less than 5% of the patients will develop a relevant clinical manifestation. Thus, we conclude that nonsteroid anti-inflammatory drugs cause asymptomatic gastric ulceration. Long-term treatment with nonsteroid anti-inflammatory drugs is accompanied by an annual risk of 1 to 4% of life-threatening peptic ulcer complication. This risk increases to a degree proportional to the dose taken, with bleeding being predominant. 300 mg of aspirin triples the risk of bleeding from ulcers, while 1,200 mg cause a 6-fold increase. Furthermore, it is estimated that approximately 50% of peptic ulcer perforations are due to nonsteroid anti-inflammatory drugs. At increased risk are aged patients, those with a history of ulcer disease, those taking corticosteroids or anticoagulants, and those who already suffer from an organ failure. The mechanism of action of nonsteroid anti-inflammatory drugs is multiple. A local effect has been speculated through the alteration of the activity of surfactant phospholipids, and the decrease of the hydrophobic character of the mucus layer. A systemic action derives from the non-selective inhibition of cyclooxygenase isoenzymes COX-1 and COX-2, which leads to the inhibition of prostaglandin synthesis. Inhibition of prostaglandin synthesis by inhibition of COX-1 suppresses many of the stomach's defense systems. It reduces blood flow, cell proliferation, and mucosal reconstitution, secretion of bicarbonate and mucus, basal acid secretion and mucosal immune function. Selective inhibition of COX-2 reduces but does not eliminate the ulcerative potential of nonsteroid anti-inflammatory drugs. The role of nitrogen oxide and hydrogen sulfide is still under investigation. Helicobacter pylori and nonsteroid anti-inflammatory drugs have a synergistic ulcerogenic action. Treatment with nonsteroid anti-inflammatory drugs during an active Helicobacter infection will maintain and enhance the harmful effect of the infection. Besides, complete cure of an ulcer from nonsteroid anti-inflammatory drugs requires the eradication of Helicobacter. Ulcers non-related to Helicobacter or nonsteroid anti-inflammatory drugs are rare. In these cases, an underlying cause should be sought. Cameron's ulcers located at the gastric cardia are caused by strangulation of the stomach in a hiatal hernia. Cushing's ulcers or stress ulcers are seen in patients who are critically ill, under mechanical ventilation, with traumatic brain injuries and impairment of vital functions. Curling ulcers are met in patients with burns. Multiple ulcers extending beyond the first part of the duodenum, or even to the beginning of the jejunum, imply the existence of a gastrin-secreting tumor, i.e. gastrinoma. Zollinger-Ellison syndrome often involves diarrheas in an emaciated patient, while diagnosis is easy with the determination of serum gastrin. Ulceration can also be a manifestation of Crohn's disease, vasculitis, tuberculosis, or cytomegalovirus infection of the digestive tract, etc. The incidence for uncomplicated peptic ulcer disease in Western world is approximately 1 in 1,000 persons, and is slightly lower for the complicated one. It appears to be influenced by age. For complicated ulcers, the incidence increases steadily with increasing age, but for the uncomplicated ones, the incidence peaks in middle age and then remains constant. From the 80s and onwards, there seems to be a decrease of the incidence of peptic ulcer and its hospitalization needs. Like the needs for hospitalization, mortality seems to decrease in the United States. This is attributed to the identification and treatment of causative factors and especially Helicobacter pylori. However, despite this reduction, both the need for hospitalization for upper gastrointestinal bleeding and in-hospital mortality from perforation remain high. The reduction of the ulcer incidence can be explained by the recognition of Helicobacter's role and its eradication, by the increasing use of gastroprotective drugs, by the switch from non-steroid anti-inflammatory drugs towards cyclooxygenase 2 inhibitors such as coxives. At the same time, a negative effect is caused by the increasing use of non-steroid anti-inflammatory drugs for cardiovascular diseases and the aging of the population. Older age means increased chances to become infected with Helicobacter pylori. Older people are at increased risk of developing complications, which will also be more severe. Furthermore, the likelihood of taking non-steroid anti-inflammatory drugs either for therapeutic or preventive reasons is higher. The typical manifestation of peptic ulcer disease, although characteristic, is nonspecific. The average age of gastric ulcer patient is 50 to 60 years old. Duodenal ulcer patients are younger by a decade. The main symptom is epigastric pain, which shows periodicity. In duodenal ulcer, the pain is most common during fasting. Hunger pain often wakes the patient at night and subsides with food intake. On the contrary, in gastric ulcer patients the pain does not subside, and may even aggravate by food intake. Concomitant dyspeptic symptoms such as bloating, belching, early satiety, vomiting, intolerance of fatty foods, nausea, or even heartburn, are quite often. These are also nonspecific, as they can also appear in patients with symptomatic gallstone disease, or GERD esophagitis, etc. Reduction of food intake due to the symptoms results in weight loss, a condition that resembles malignancy. Strikingly, pain, which is supposed a typical symptom of peptic ulcer disease, may be absent in up to 30% of elderly patients. Approximately 1 out of 5 patients can be completely asymptomatic until the disease manifests for the first time with a complication. 15%, especially of older age, will be diagnosed by significant bleeding, hematmesis or melena, 5 to 10% by perforation and peritonitis. Taking the medical history, the age of the patient, a possible treatment with over-the-counter medication, such as aspirin or antacids, and the presence of alarming symptoms are of great importance. Alarming symptoms may indicate the development of a serious, potentially life-threatening complication. A history of hematmesis, hematochezia, or melena implies gastrointestinal bleeding. A sudden, severe, sharp pain in the abdomen, epigastrium, or in the back may indicate perforation. Undigested food vomiting can be a result of pyloric stenosis. Significant weight loss may be due to the development of cancer. Both old age, greater than 55 years, and the appearance of alarming symptoms mandate an immediate and thorough investigation. Physical examination is inconclusive except for complicated ulcers. Complications are bleeding, perforation, obstruction. Similarly, laboratory investigation is not informative. Chronic blood loss from ulcer microhemorrhages can lead to hypochromic microcytic anemia. There are no abnormal values in serum biochemistry, while serum gastrin may be slightly increased when the patient is under proton pump inhibitors, or histamine 2 receptor antagonists. Gastrinoma patients are characterized by highly elevated gastrin levels and diarrhea, but chiefly from a long course of symptoms. There is a tendency to bypass investigation in patients living in areas with high prevalence of Helicobacter. Also in patients younger than 50 years old. And in patients without alarming symptoms. In these cases, upfront eradication of Helicobacter is indicated, and investigation will be conducted only if the symptoms persist or reappear. Upfront investigation is reserved for those older than 50 years old because they may harbor a malignancy, those with alarming symptoms because they are at risk for complications, and those living in areas with a low prevalence of Helicobacter. Ideally, every patient must be investigated, but this strategy seems cost-effective. The diagnosis is set endoscopically with 90% accuracy. Endoscopy will identify the ulcer, clarify its location and morphology, rule out malignancy with tissue biopsies, and finally, search for Helicobacter infection. Alternatively, the patient can undergo a barium meal. The ulcer and its position will again be identified with an accuracy that approaches 90% in double contrast. However, Helicobacter cannot be searched for, and tissue biopsy is impossible although radiological signs indicative of malignancy do exist. A benign ulcer is depicted as a collection of barium, usually round, or ovate, projecting outside the contour of the lumen, with a smooth outline. The mucosal folds converge smoothly towards its crater. It may be characterized by Hampton's line, which is a very thin radiolucent line at its neck due to tissue edema. On the contrary, a malignant ulcer has an abnormal shape and is localized in a mass that can be inside or outside the lumen with abnormal rim, and abnormal thickened mucosal folds. Investigation for Helicobacter pylori infection is mandatory. When there is no tissue material, Helicobacter infection can be evidenced indirectly by antibodies against Helicobacter in serum, or antigens of Helicobacter in feces. More widespread is the determination of urea in exhaled air, breath test. The patient drinks a solution of urea labeled with radioactive carbon. If there is Helicobacter and urease in the stomach, the breakdown of urea will lead to exhalation of radioactive carbon dioxide. The genetic material of Helicobacter can be detected in tissue biopsy by PCR, a particularly sensitive and rapid method, but with an increased number of false positive results. The easiest and most widespread method is urease detection. This is done by inoculating the sample in a material containing a pH-sensitive indicator, usually Congo red. If urease is present, the produced ammonia increases the pH, and the indicator changes color usually from yellow to red. Helicobacter can also be seen in microscopy on pathology examination. Finally, culture and isolation will determine susceptibility to antibiotics, but it takes about 4 weeks. The choice of method depends on various factors. Treatment with antibiotics, or with PPIs, affects the activity of urease, and should be stopped for at least 7, or better, 14 days. Similarly, active bleeding affects urease activity, so ruling out Helicobacter demands all the 3 tests, CLO, microscopic examination, and UBT, to be negative, or the detection of antigen in stools. Peptic ulcer disease is typically treated conservatively nowadays. Surgery has a role in persistent or complicated disease. The basic principles of conservative treatment are lifestyle and diet modification, Helicobacter eradication, pharmacological suppression of gastric acid, and enhancement of mucosal defense. Regarding diet, withdrawal of foods that increase gastric acidity or slow down gastric emptying is important. Meals should be light, and at regular intervals. Snacking in between meals is better avoided. Avoidance of foods rich in fat, fried foods, sauces, spices, coffee and cola is recommended. They should be replaced by low-fat milk and dairy products, poultry, fish, eggs, fruits, vegetables and fiber. Smoking and alcohol should be stopped. Of utmost importance is Helicobacter eradication with antibiotics combined with proton pump inhibitors. The treatment is considered successful when Helicobacter cannot be detected 4 weeks after its conclusion, with the patient off anti-secretory therapy for at least 1 week. After the Maastricht 2 consensus, the treatment lasts 7 to 14 days. Prolongation of antibiotic treatment from 7 to 10 days increases the eradication rate by 4%, and to 14 days by 5%. A combination of antibiotics increases the eradication rates and shortens the course. The commonest regimen is clarithromycin 500 mg twice daily plus amoxicillin 1000 mg 3 times daily for 10 days. In gastric and complicated duodenal ulcers, PPIs are continued for 4 to 8 weeks, allowing for the ulcer to heal. This is not necessary for simple duodenal ulcers. In duodenal ulcers, eradication must be confirmed by a non-invasive method, such as exhaled air testing. In contrast, gastric ulcers need repeat endoscopy and biopsy to exclude malignancy. In 10 to 20% of the cases, eradication fails for various reasons: wrong combination of antibiotics, antibiotic resistance, poor patient compliance, short treatment, genetically determined variations in drug metabolism, etc. In case of strains resistant to both metronidazole and clarithromycin, a second-line, and perhaps a third-line regimen can be prescribed. Of course, in difficult cases, microbiological cultures and antibiogram will indicate the solution. Complicated ulcers need an up to 8 weeks prolonged anti-secretory treatment, until healing is endoscopically confirmed. In these cases, eradication must be verified by histological examination of tissue biopsy. The dictum "no acid, no ulcer," of K. Schwartz, remains the basic dogma of treatment. So far, pharmacology has targeted the acid itself, the histamine 2 receptors of the parietal cell, and finally, the proton pump of the parietal cell. After the initial report of the American physician B.W. Sippy, the treatment of peptic ulcer was based on the reaction: base buffers acid, producing salt, and water. Antacids, such as aluminum or magnesium compounds, offer a buffering effect, but their dosing regimen, 50 to 100 ml every 4 hours, is difficult to keep. Anti-secretory treatment was initially based on histamine 2 receptor antagonists, at first cimetidine, and later ranitidine. These two are not in use today. Famotidine, the newest, single daily dose drug of this class, is still in use. H2 receptor antagonists can heal up to 90% of ulcers after 8 weeks of treatment. However, they have been mostly replaced by the even more powerful proton pump inhibitors. A single dose of proton pump inhibitors on an empty stomach abolishes completely acid secretion from parietal cells. Effectiveness appears to be greater in duodenal ulcers. In uncomplicated gastric ulcers, where the cause is insufficient mucosal defense, H2 receptor antagonists, high-dose PPIs, and low-dose PPIs, are all equivalent. An alternative therapeutic target is enhancing mucosal defense. Misoprostol, a synthetic analog of prostaglandin E2, affects positively all the defensive systems of the stomach. It increases the thickness of mucus layer and the bicarbonate secretion, and promotes cell proliferation and wound healing. However, the effective dosage of 200 micrograms every 6 hours presents significant gastrointestinal side effects, while lower doses are ineffective. Sucralfate, a sucrose aluminium sulfate complex, has a different mechanism of action. It binds to the mucosa, prevents mucus breakdown, and increases bicarbonate secretion. At a dose of 1 gram or 4 times daily, it has an efficacy of 70 to 80%, equivalent to histamine 2 receptor antagonists. It has been much displaced from therapeutics after the superiority of proton pump inhibitors. For patients who need nonsteroid anti-inflammatory drugs, regardless of the reason, cyclooxygenase 2 inhibitors appear to be less ulcerogenic, but have cardiovascular side effects. Furthermore, selective COX-2 inhibition is not beneficial in cardiovascular patients, and low-dose aspirin treatment is mandatory. A possible algorithm, based on the patient's cardiovascular risk, is the following. If the cardiovascular risk is low, then they can take COX-2 inhibitors. Alternatively, they can receive non-steroid anti-inflammatory drugs combined with gastroprotection, which can be either anti-secretory treatment or misoprostol. If on the contrary, the cardiovascular risk is high and aspirin is mandatory, COX-2 inhibitors are contraindicated. In this case, non-steroid anti-inflammatory drugs combined with gastroprotection are preferred. Gastroprotection can be either misoprostol or anti-secretory treatment. In summary, patients with Helicobacter infection undergo an eradication regimen with antibiotics and PPIs lasting 10 to 14 days. Gastric ulcer patients receive additional anti-secretory treatment for 4 to 8 weeks. This is not necessary for duodenal ulcer patients. If the first-line regimen fails, a second-line one, and perhaps a third-line one follows. If these fail too, then culture and sensitivity testing are required. In ulcers due to non-steroid anti-inflammatory drugs, prophylactic anti-secretory treatment is an option, but the patient's medication should be re-evaluated in total. In the absence of both Helicobacter infection and non-steroid anti-inflammatory drugs treatment, an underlying cause and its appropriate treatment should be sought for. Otherwise, high doses of PPIs for at least 8 weeks can be attempted, although no patient should remain undiagnosed. If conservative treatment does not work, 12 weeks maximum, the patient is a surgical candidate. The effectiveness of medical treatment of peptic ulcer disease has reduced the role of surgery dramatically. Candidates for surgical treatment are those who cannot receive or are not suitable for medical treatment, those whose treatment was unsuccessful, or had ulcer recurrence, those at increased risk for complications, for example, mandatory steroids or non-steroid anti-inflammatory drugs, transplant patients, etc. Those with complicated ulcer, bleeding, perforation, obstruction. Complications either represent a life-threatening condition, or minimize quality of life. Interestingly, a significant percentage of complicated peptic ulcers concern patients not infected with Helicobacter. These will not benefit from eradication treatment. The appropriate operation must be individualized each time, considering both patient status and setting. For example, a neglected duodenal ulcer may require an elective operation for pyloric stenosis, or an emergency operation for severe bleeding. The conditions are different, as are the indicated operations. Schwartz's dictum, no acid no ulcer, remains the basic tenet also for surgery. Gastric acidity can be surgically suppressed by denervating the stomach through vagotomy, and by resecting the gastrin-producing cells through antrectomy. Truncal vagotomy is the division of both vagus nerves as they enter the abdomen through the esophageal hiatus. It abolishes both neural stimulation of parietal cells and neurogenic gastrin release. Basic acid secretion is reduced by 85% and peak acid secretion by 50%. It is an effective operation with only 10% recurrence rates. However, in 30% of the patients, pyloric denervation causes spasm of the pyloric sphincter, delay of gastric emptying, and development of secondary prepyloric ulcers known as Dragsted's ulcers. Thus, truncal vagotomy must be combined with a drainage procedure. Truncal vagotomy splits up the hepatic branch of the anterior vagus nerve, and the intestinal branch of the posterior vagus nerve, so it denervates non-selectively the viscera. This in turn leads to late morbidity, mainly dumping syndrome and diarrhea. For this reason, the technique of selective vagotomy was developed. In selective vagotomy, the gastric branches of the vagus are divided immediately distal to the origin of the hepatic and intestinal branches. This procedure denervates selectively the stomach but not the rest of the viscera. Again, a drainage procedure is needed because pyloric spasm still occurs in 30% of patients, and particularly those who lack the pyloric branch of the hepatic branch of the anterior vagus. The effectiveness of the procedure is almost equal to truncal vagotomy. Late morbidity is slightly improved while surgery is technically more difficult. Drainage procedures include Hynek-Mikulets pyloroplasty, where the pylorus is opened longitudinally and sutured transversely, enlarging the lumen. Phenesplasty is created by extending the pyloric incision of Mikulets plasty towards duodenum. A similar procedure is the gastroduodenal anastomosis as described by Jaboulet. The many types of drainage procedures indicate that there is no operation suitable for all, but each case should be individualized. Hynek-Mikulets pyloroplasty is the most common because it is the simplest and most effective. However, if duodenal exploration is required, for example in a bleeding duodenal ulcer, then phenesplasty is preferable. On the other hand, if fibrosis and inflammation around duodenum are excessive, then a gastroduodenal anastomosis offers the solution. All the previously mentioned drainage procedures prerequisite that the first part of the duodenum is amenable to surgical manipulation. If not, or if the gastric outlet canal is particularly deformed, then a simple gastrojejunal anastomosis will do. In such a case, vagotomy must be legi artis executed, or the patient must receive adjuvant anti-secretory treatment, to minimize the possibility of anastomotic ulcer. Parietal cell vagotomy is the division of all the terminal gastric branches of the vagus nerve except the final branch of the Latarjet's nerve, commonly called crow's foot, which innervates pylorus. Denervation includes the distal 6 cm of the esophagus and extends up to about 6 cm centrally to pylorus. In this manner we denervate selectively the parietal cell areas while we preserve pyloric neurosis. Drainage procedure is thus not required, and side effects, especially dumping syndrome, are minimized. The operation is time-consuming, so is not appropriate for emergency situations such as acutely complicated ulcers. Ectopic parietal cells are not infrequent, causing residual acid secretion. This explains the higher rate of ulcer recurrence, from 4 to over 25%. Taylor proposed anterior ceremyotomy with posterior truncal vagotomy. This is faster, easier and is executed laparoscopically with great ease, producing equivalent results. The main advantages of parietal cell vagotomy are safety and low rate of side effects, while its main disadvantage is the high recurrence rates. Finally, the most effective operation in terms of gastric acidity reduction is truncal vagotomy combined with gastric entrectomy. This denervates the gastric body and removes the gastrin-producing stomach. Thus, both the cephalic and gastric phase of acid secretion are eliminated. It has higher morbidity and mortality rates compared to the rest operations, especially in acutely complicated ulcers. Furthermore, it is particularly morbid when the duodenum is strongly inflamed or scarred, and is accompanied by intense diarrhea. To avoid diarrhea, the truncal vagotomy can be substituted by the technically more difficult selective vagotomy. Recurrence rates are as low as 2%, and for these a branch of the posterior vagus, known as Grassie's nerve, is probably responsible. This derives cranially to the intestinal branches and innervates gastric fundus. Surgical treatment of gastric ulcers should always include pathologic examination of the ulcer, to rule out an ulcerative form of cancer. Type 2 and Type 3 gastric ulcers share a common cause and a common treatment with duodenal ulcers. However, parietal cell vagotomy presents unacceptably high recurrence rates and is better avoided. All the rest acid-reducing operations are effective enough, but they have to be followed by resection, or at least biopsy of the ulcer. The typical treatment for type 1 gastric ulcers is distal gastrectomy, including the ulcer itself. In this case, vagotomy is not required. Literature indicates that a highly selective vagotomy with concomitant resection of the ulcer has equally good results. Type 4 ulcers are frequently secondary to an underlying cause which must be treated first. For example, in Cameron ulcers which are due to hiatal hernia, the treatment is hiatal hernia repair. Total or central gastrectomy for ulcer disease was abandoned due to high morbidity and mortality in the past, and distal gastrectomies are precluded due to the localization of the ulcer. Kelling-Maddelner procedure, which is distal gastrectomy with multiple ulcer biopsies to rule out malignancy, had disappointing recurrence rates. A variety of ingenious procedures have also been described. Pochet's operation is distal gastrectomy extended orally, to resect the whole lesser curvature including the ulcer. In Mayo's operation, the lesser curvature is resected, and a gastric tube is constructed from the greater curvature. Xtend's operation is subtotal gastrectomy including part of the cardia and esophago-gastrojejunal anastomosis. The effectiveness of all these unusual procedures has not been evaluated by modern clinical studies, both because the frequency of intractable type 4 ulcers is low and because surgeons are not familiar with them. To restore continuity of the digestive tract, the gastric stump can be anastomosed with the duodenal stump in a gastroduodenal anastomosis, commonly called Billroth 1 reconstruction. Alternatively, the gastric stump can be anastomosed with the jejunum in a gastrojejunal anastomosis, commonly called Billroth 2 reconstruction. Billroth 1 reconstruction resembles the normal track and does not lead to many of the post-gastrectomy syndromes. It requires both a healthy duodenal stump and a sufficient length of gastric remnant for a tension-free anastomosis. On the other hand, Billroth 2 anastomosis avoids tension in the anastomosis but requires a safe closure of the duodenal stump. The gastrojejunal, Billroth 2 anastomosis can be constructed ventrally or dorsally to the transverse colon, and is called anticolic or retrocolic respectively. The retrocolic anastomosis passes through the transverse mesocolon, therefore is often referred as transmesocolic. Sometimes it is referred to as omega because the jejunal loop resembles the Greek capital letter omega. In transmesocolic Billroth 2 anastomosis, the stomach must be fixed in the transverse mesocolon, minimizing the chances of jejunal strangulation in the mesocolic gap, and the development of afferent, or efferent loop syndrome. In Billroth 2 anastomosis, the biliopancreatic fluids pass through the gastric remnant and may cause alkaline gastritis. To avoid this and bypass the stomach, Braun added a lateral jejunal anastomosis. An alternative reconstruction is the Roux-en-Y, in which an isolated jejunal loop is anastomosed with the gastric stump, carrying food distally and thus called trophic loop. The jejunal loop that represents the continuity of duodenal stump is called the biliopancreatic loop. The digestive continuity is restored by anastomosing the trophic loop with the biliopancreatic loop, at about 40 cm from the gastrojejunal anastomosis. Roux-en-Y reconstruction is devoid of many of the disadvantages of the Billroth anastomosis, especially duodenogastric reflux. Yet, it is not appropriate for antrectomies because the large gastric remnant predisposes to gastric stasis. On the other hand, the trophic loop should not be very long, greater than 45 cm, because it malfunctions and cannot propel its contents distally, a condition commonly called Roux syndrome. Furthermore, all gastrojejunal anastomoses are prone to the development of anastomotic ulcer if gastric acidity has not been minimized, either by truncal vagotomy, or subtotal gastrectomy. Of course, Roux-en-Y reconstruction, like omega Braun, can be applied in total gastrectomies, but total gastrectomy is not a routine operation for gastric ulcer. Surgery for uncomplicated peptic ulcer disease is particularly safe. Mortality is less than 1%, and morbidity less than 5%. Common postoperative complications are bleeding, infections, mostly pulmonary, and delayed gastric emptying, although the latter is not clearly defined. Treatment of complications is most often conservative, reoperation is rarely indicated. The late complications of gastrectomy, called post-gastrectomy syndromes, are frequent as they affect 1 out of 4 patients. However, they are temporary, as they will be permanent in less than 1%.